I try to strike up a conversation because men treat prostate cancer like a scarlet letter. I know guys that got it that won't say anything about it. And so I try to take the embarrassment away. If I can save one person, I've done my job right.
Hi, this is Patrick.
And this is Laura.
And you're listening to This is Cancer.
Brought to you by Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis. National leaders in cancer. Should I start the conversation today, Patrick?
I'll start this one because it's a room full of men, and I feel like it's my responsibility.
All right.
Today we're talking about prostate cancer, and we're joined by Kevin, who's a Siteman Cancer Center patient, and his two Washington University physicians, Drs. Bullock and Pachynski. Thank you all for being here today.
Thank you for inviting us.
Thank you.
Dr. Bullock and Dr. Pachynski, would you mind telling us what you do at Siteman Cancer Center?
I am a urologic surgeon, and I am the director of men's health. I treat men who have voiding dysfunction, men who have prostate cancer. I also do a lot of erectile dysfunction.
Gotcha. Dr. Pachynski?
I'm a medical oncologist specializing in genitourinary malignancies. That just means prostate, kidney, bladder cancer.
Okay.
The medical oncology side is the hormone therapy, the chemotherapy, the immunotherapy.
I don't know if people realize how common prostate cancer is when it comes to how often men are diagnosed with it, especially as they age. Kevin, how old were you when you were diagnosed with prostate cancer?
55.
Now, is that fairly young?
No, that's not young to be diagnosed with prostate cancer. African-American men tend to get prostate cancer at a slightly younger age than whites. That's why we recommend screening for people at high risk, African-American men and men with a positive family history probably should get their first PSA screen at around 40 and maybe again at 45, depending on what the initial number is. But the average age of prostate cancer is 65, but it's not uncommon to pick up prostate cancer at 50, 55.
Gotcha. I want to get to more of the technical side of the testing and what your prostate actually does. And there were men and women asking those questions here in our office today, believe it or not. Mm-hmm. But Kevin, tell us about your diagnosis and whether or not you were actually getting screened at the time when you found out about the...
Yes, I get screened every year. I've been taking physicals since 1987, a yearly physical. And when I had my physical in 2017, my PSA was elevated. So they recommended that I go see a doctor, and Dr. Bullock was recommended to me. So I went to see Dr. Bullock. We had a conversation, and he told me it was elevated. He recommended a biopsy.
So maybe this is a good point to ask something I've been wanting to for a while. What is a PSA test?
So PSA stands for prostate-specific antigen. It's actually a protein that is given off by both normal prostate cells and prostate cancer cells. It basically gives us a rough idea of how many either prostate cells or prostate volume or prostate cancer cells are in the body. Okay, so it doesn't tell us if it's normal prostate cells or prostate cancer cells or exactly what's going on, but it gives us a rough indication of how many prostate type of cells are in the body.
So Kevin, when you found out that your PSA levels were high, did you even know at that point what it meant, what your prostate did? Because I know there's a lot of people that don't even really know, men and women.
I didn't know what the prostate did, but I knew what high meant, right? I knew high meaning that I needed to get it checked further. So I did have indications that maybe something was wrong.
Did you ask Dr. Bullock, what does my prostate do?
What point do you figure that out?
Well, I'm pretty sure we had that conversation because, once the prostate is out, you don't have any more children because you can't secrete that anymore.
So it's not a matter of you can't have sperm in your semen. It's a matter of you can't have semen?
So that's a good distinction. So your ejaculate is the fluid that you see when you climax. Men who get a vasectomy, they have a normal volume, but up under a microscope, they have no sperm cells. The sperm cells are the microscopic things that gets a woman pregnant. So the prostate is where the majority of the liquid that you see when you climax, that's where it comes from. If you remove the prostate or many other things to the prostate, then you disturb the volume.
A lot of stuff from the prostate helps your guys swim, so to speak. Correct, Dr. Bullock?
Correct. So an ejaculate volume is about 1 teaspoon, 5 cc's. only 5% of that at most are your sperm cells. But there's a lot of things in that liquid, like PSA's in that liquid. PSA is essential to help take off the cap off the sperm for the sperm to fertilize the egg. There's all kinds of nutrients. Now, mind you, on lay people term, we say that liquid comes from the prostate, but that's actually not true. 85% of the liquid comes from the seminal vesicles. But now we're getting in a whole different anatomy level depth that probably not necessary.
Now we're into a high-tech medical podcast.
We should just say the fluid comes from the prostate, but there's someone out there says that's not true. 85% comes from the seminal vesicles. 10% comes from the prostate, and 5% comes from your testicles.
But Dr. Bullock, you're like, I know that. I work at Siteman, but we're just going to keep it simple.
Right, that's right.
Gotcha.
I appreciate that. It's more like, look, yeah, sure, there's more to it, but you don't need to know.
One of the most important things in it is fructose, sugar.
Oh.
Sperm got to have food to live on while they swimming around for a couple days.
Sperm needs to have food?
Well, fructose is in the ejaculate. And so
it makes sense that sperm men need food. I mean, it all makes sense to me now.
Well, I mean, just think about it. Those guys got to get to the eggs.
They got to swim.
They got to go.
Yeah.
And they got to get through the cervix, the uterus. They got to hang out for a while, get through all this stuff, proteinaceous,
they need energy.
mucousy stuff. And so a lot of what comes out of the prostate and that seminal fluid helps facilitate that.
Gosh, our bodies are amazing, truly. Every time I hear some medical explanation about our bodies, I've
already learned so much. Like, I didn't know. I mean, I know where the prostate is, and I know what it does.
I don't know where it is, by the way.
That's okay.
Okay, we'll get to that.
But
in a little
bit. It is commonly not known, as we've already established. I mean, Kevin, you had to be told, right?
Right.
I think a lot of people don't know. But what I didn't know is that you could still, you can theoretically still have sexual pleasure and like erection and climax without a prostate. It's just that there won't be semen, basically.
The contractions still happen in your pelvis without a prostate.
So, Kevin, when you started learning more about it, when you were talking to Dr. Bullock, was there any part of you that was, I guess we should back up to say, what was your plan when you found this out? What was the plan you first came up with about how to treat this?
Well, when he said they had cancer in your body, right? Well, cancer don't belong in your body, right?
Right.
And so I always ask the doctor a question, no matter what doctor is. If I was your brother, what advice would you give me?
Good question.
And he said, I would recommend you get it out. Well, I know it don't belong in my body. And then, so I decided to take it out.
But there have to be some levels and variations of what you can have after you have your prostate removed. There has to be. Like, what do you guys talk about when you hear about the surgery, Dr. Pachynski? What are the...
Yeah, I mean, I think Dr. Bullock can speak to this a little more, but in terms of the anatomy, but there are nerves that come back down, kind of innervate the bladder, and the prostate's right under the bladder. And
okay, so the prostate's under the bladder.
Yeah.
Okay,
and so that can affect your ability to have an erection.
Sure.
But it doesn't mean if you have surgery or radiation that 100% it is going to. Mm-hmm. So I think those are important discussions to have with your surgeon and or radiation oncologist.
There's a spectrum of possibilities. It's not black or white, I understand.
So I always tell people to keep in mind that one of the most quoted articles in all of urology is the Massachusetts Male Aging Study. And believe it or not, for decades, it's been the #1 article that's looked up in urology. And it says that 52%, so a little bit more than half of all men between 40 and 70 have erectile dysfunction.
Wow.
52. So if you take the average man in his 60s, 1 in 4 not able to get it started. Mm-hmm. And some articles suggest that half of all men at age 70 can achieve an erection good enough to begin intercourse. So we're looking at men with an average age of 65. So if you come into the surgery or radiation and the erections are already subpar, yes, your chance of the erections being worse is high. But keep in mind, who fixes problems with erections? Urologists.
You do.
And so we have all kinds of treatments. There's pills, there's shots, there's vacuums, there's rings, there's implants. There's all kinds of ways to make a man better than he ever been.
And so when you had that surgery, that was it. That the cancer was removed from your body. There was no radiation required, correct?
Not at that time.
Not at that time.
So outside of surgical intervention, is radiation typically the first first prescribed, treatment plan for prostate cancer?
So if it's localized, it's basically, if you want a curative approach, it's either surgery or radiation.
I see.
There are those kind of uncommon instances where you would say, you know what, your prostate cancer will not kill you. It's, your heart's not doing so great. So let's not do surgery. Let's not do radiation. We can either watch it or we can give you some hormone therapy and kind of temporize it and just slow it down.
How does that work?
Usually we use this in the more advanced setting, if the prostate cancer has come back or is spread metastatic. But the main food for these prostate cancer cells is testosterone. Okay, so that primarily fuels the prostate cancer growing. And so one of the kind of main treatments for more advanced prostate cancer is basically getting rid of that testosterone. And usually the older you are, your testosterone kind of wanes the older you are kind of naturally. So, if you're in your 80s, 90s, most of my patients who get hormone therapy at that point really don't notice much different. That's a different story if you're in your 40s or 50s, right? Now, there are a number of different studies that have somewhat recently come out to show that if you go on this hormone therapy, one of the main ways you can reduce those side effects and symptoms is actually by vigorous exercise, right? Aerobic, weights, good diet, and you can minimize those side effects.
So that brings up a good point. And I always tell my patients, when you try to explain grades and aggressiveness of prostate cancer, I always relate it to dogs, right? And it sounds funny, but it's true. Because we're trying to explain differences between high-grade cancer, medium-grade, or low-grade cancer. And I say, think about it like dogs. If you had a knife, a gun, and mace in your pocket, and you were chased by a 2-month-old poodle, which one would you pull out? And a lot of people say, well, I guess I would mace him. And my question would be, why would you mace a 2-month-old poodle? Like, what's he going to do to you?
Right.
He's going to do nothing to him. You should pick him up and put him back over the fence. But what if you're being chased by a hyena and a wolf? Now you're talking. You got to shoot them, right? And so there's 25% of prostate cancers that should be observed because we'll biopsy a guy with a PSA of 7. His exam is benign to exam. There's 1 or 2 cores with 5% of low-grade prostate cancer. That's the kind of cancer that we know, based on studies, has only a 7 out of 100 chance of progressing, requiring treatment over the next 10 years. But the problem is, some men will say, my cousin is being watched, I want to be watched. Well, he's being watched because he's being chased by a poodle, but you're being chased by a Rottweiler. Those are 2 different dogs, dude, right?
No, that makes sense.
And so based on the grade of the cancer and how much you have, that dictates how we treat.
That totally makes sense. I also appreciate that we're using an analogy about dogs when referring to a cancer that only men are faced with because men are dogs.
Oh, Patrick.
I mean, not just men. Dogs get prostate cancer.
Yes,
so,
yes.
I mean,
Yes.
I did love the junkyard dog.
I like that.
Yeah, thank you. I guess really what I was getting at is like you wouldn't use chemo or immunotherapies. It's like, look, this is tried and true.
Yeah, I mean, higher PSA tends to correlate with more disease and more likelihood that it's spread outside of the prostate. And one of the newer tools that we have in diagnosis of prostate cancer is something called the PSMA PET scan. So we used to use kind of we'll still use in a lot of instances, the CAT scan, something called the bone scan that looks at the bones, and MRIs of the prostate and the pelvis. The PSMA PET scan uses a tracer, so you inject it IV. It actually binds to the prostate and prostate cancer cells. It's got a little radioisotope on there. And then you wait, usually about 30, 45 minutes, sit under a camera, and it picks up, it's very sensitive, it picks up any prostate or cells that express PSMA.
In the rest of your body.
The entire body. Not just the prostate, not just the pelvis. And so now what's happening is we're getting these PSMA PET scans at time of diagnosis, right? You get a biopsy of your prostate, you find cancer on there. There's a high chance you're going to get one of these PET scans. We're picking up prostate cancer that's outside of the prostate way more often than we used to 5-10 years ago.
And an important test to get if their levels are high.
Correct.
Kevin, what was your PSA level when you had your surgery?
It was 5 over 5.
What is a healthy level?
Anything below 2, right?
Well, this number, bottom line, in general, someone says, what's a normal PSA? You say a PSA under 4. But we screen in the community, and we might screen a person 40, right? So a 40-year-old African-American man with a PSA of 3.6, that's not normal, right?
He's not old enough.
That's right. His should be 2 or under. So if you have a 75-year-old man whose PSA is 5, we say, well, that's probably normal for your age.
Gotcha. So Dr. Pachynski, you mentioned earlier that you had the surgery. Sometimes there can be a couple little cells left of those prostate cancer cells. And so after someone has a surgery, they're going to go keep getting that PSA test taken, right? And Kevin, you were doing that.
Yes.
For how many years?
I still do it.
Okay, you still do it.
Yeah.
So what about year 4 or something, or 3 was when you found a non-zero number?
My PSA never went to 0. It was like 0.00.1, right?
Okay.
And over the last few years, it had been going up, and I think the highest it got is like 0.7. So I had the PSM test, what Dr. Pachynski was talking about, where they injected me. They didn't find it, so it was no cell. They didn't find any cells, right? Mm-hmm. No cancer cells. However, I had 37 days of radiation treatment because they wanted to treat the pelvis bed. He said, "Good news, we don't see any cells, but we're just going to treat it anyway because your PSA should have been 0." And at the last reading, it was 0.00.1.
Just so people out there listening who might have prostate cancer. So after your prostate is removed, your PSA should be under 0.1, under 10 cents, right? Mm-hmm. 0.1. If a very selective test would tell you your PSA down to 1 penny, 0.01, right? So if that PSA goes above 20 cents, 0.2, and then it goes to 30 cents, 0.3, 0.7, that means, bottom line, your PSA is never going to be 0.7, right? And his shouldn't have been 0.7. Mm-hmm. And so if his PSA goes to 0.7, that means there's some prostate cells in his body.
Even if you can't see them.
Yeah, I mean, it takes, I forget, there's a calculation out there. It takes millions and millions, if not like a billion,
I'm sure it's in the billions,
cancer cells all together to actually be able to see even on a PSMA PET scan. So by that time, there's so much prostate cancer built up. When you do, after surgery, if the PSA is coming back up and you measure, you always got to measure it multiple times, right? You can't just do one reading. If it does look like that's a real rise in the PSA, there's some newer studies out that, suggest and show that you should actually do the radiation earlier rather than later, right? So if you've had the surgery, PSA, let's say, goes to undetectable, and then it starts coming up, and you're like, okay, well, the prostate cancer cells are coming somewhere. You don't want to wait till that PSA is 1.7 or 2 or 5.
You're just flirting with
right.
cancer
and
metastasizing.
So we know from these randomized, what we call salvage radiation trials, that if you treat with radiation after surgery at a lower PSA, the outcomes long-term are better than if you wait until your PSA is 2, 5, 10, et cetera.
So, Kevin, in your case, you had this surgery, they removed your prostate, and now you're keeping up with is it like annual, maybe quarterly?
Yeah, I do like I think it's now 6 months.
Gotcha. So pretty frequent PSA tests,
Yep.
And then you guys noticed a trend kind of like what Dr. Pachynski was noting. So at that point, now you're realizing there might be another dog back there starting in on the chase. And so you need to nip that in the bud, right?
Right.
And so you guys went with a course of radiation. You said it was to your pelvic bed, is that correct?
Yep.
And so what did that entail?
Just laying on the table every morning for 37 days. It took about 15, 20 minutes.
Yeah.
And they aim at a specific site, right? Mm-hmm. And so no ill effects.
I think that's important to hear from patients about the radiation, getting radiation after surgery. I've had a number of patients who have been very concerned about the toxicity, the side effects from radiation. I mean, it sounds, surgery is acute, it happens, you recover. Radiation, you're getting zapped product, and if you look at the data overall, in general, it's very well tolerated. I mean, I've had many patients who are just afraid of the concept, or maybe there's been one person who they knew that got a different type of radiation and had a
different cancer, totally different cancer.
And so, I think it's really important because if you have surgery as your first treatment for the localized prostate cancer, that radiation is your last curative option, right? And so I think it's important. And in general, the vast majority of patients who go through it tolerate it very well. I mean, it's very effective.
This brings up a very important point of why support groups are so beneficial. And we have we have more than one. There's several prostate cancer support groups in St. Louis, just like there are breast cancer support groups and colon cancer support groups. And we've gone to so many of these support groups at different churches. Some of them are small, support group at First Baptist of Clayton, for instance, First Baptist Chesterfield. But the largest one is called the Empowerment Network, which is one of the most noted prostate cancer support groups in the country. It's clearly the largest one in the Midwest. And started by Melvin Shahid, who's a painting contractor, who when he was diagnosed 16 years ago, he couldn't find anybody to talk to him.
Really?
So he started this, and it's every month, second Saturday of the month, 10 o'clock sharp, ends at 12 o'clock sharp. And there might be 50, 60, sometimes more at every monthly meeting.
Kevin, you shaking your head. Have you been to that?
Yep, I'm a part of Empowerment Network.
Yeah, and so what is that doing for you? What have you gotten out of it?
Education. Just talking to the other patients in there. Everybody's process is different, right? Everybody had a different process. Just to listen to the stories, and it affects others more than it affects some, right? But it's a good support group.
Yeah.
Some people need that support.
Prostate cancer is a bad cancer. And one of the biggest myths of prostate cancer is, but it's prostate cancer. It doesn't kill you. 230,000 Americans will be diagnosed with prostate cancer this year. So it affects 1 in 6 African American men and 1 in 9 white men. There's 32,000 men who are going to die from prostate cancer in America this year. How many women die from breast cancer? About 38. There's far many more women age 65 than men 65. So many people think that the percentage of men who die from prostate cancer is very similar to the percentage of women who die from breast cancer. So this idea that prostate cancer is not a killer, it's the second leading cause of cancer death behind lung cancer.
In men?
And all people. I mean, and men, right? Well, no women die from prostate cancer. But
That was a dumb question.
But the number one cause of cancer death in America remains lung cancer. But as smoking drops down, prostate cancer and breast cancer become number one on each gender, followed by colorectal.
Which is so interesting to me because there's a test that you can get every year to take note of your PSA levels, right?
Right.
And so is it because not everyone is getting that checked every year, or is it because it's just a more deadly, with breast cancer, we have mammograms,
right.
Or if we are high risk, we have MRIs. If we have prostate cancer in men and there's a family history, automatically that bumps up the age in which you should be getting tested. If you're African American, it increases it even more. Why are they not doing it? I don't understand.
Well,
it's a blood test. It's not even like
it's a blood test. It's a screening test. And I mean, that's a great question. There's something called the U.S. Preventative Task Force Service that is one of these national public health agencies in the United States. And basically, there's a screening test, how good it is, and what are the outcomes. To boil it down, there was a large clinical trial in the U.S. There was another one in Europe that looked at using PSA screening, and was it essentially effective enough and cost-effective enough, and should we be doing it on everyone as we had been doing as PSA came into play in Arnold, like the 90s?
So it was approved in 92.
92.
Wow,
and actually a lot of those studies were done here at WashU, at Siteman.
A lot of the studies.
The studies that led to the PSA being approved were the Washington University PSA screening study that was run by Dr. William Catalona through our division. But at one point, we had over 50,000 men in St. Louis in that trial.
Wow.
The PSA trial. And that really is the main study that led to the PSA being approved by the FDA.
Wow.
Jeez.
And so you look at the incidence of prostate cancer diagnosis, and there's a huge spike in the 90s, right? As this simple blood test was validated and became universal, people going into their primary care providers and saying, hey, we got this new test to pick up prostate cancer. You're picking up a lot more prostate cancer than you would have. A lot of it is early localized prostate cancer. So then at some point, these two big studies were done, one in the US, one in Europe, kind of reevaluating, should we really be every man that walks into the clinic, should we be just randomly, universally sending off the PSA? And basically, the U.S. study said, it's probably not worth it because of cost and false positives and complications of a biopsy and all that. And the European study basically said it is kind of worth it, right? So the U.S. Preventive Task Force Service, I think, kind of relied more on the U.S. study and basically said, you know what, we should not be doing this on every man that walks into the clinic. And so they downgraded this recommendation that all the primary care doctors and providers across the U.S. follow, and basically said you should not be universally screening patients. And so what you see in the prostate cancer incidence and diagnosis is at that time, the diagnosis goes down, and that stayed like that for a while. And what we've seen as a result of that is that there's a higher incidence of men diagnosed with more advanced stage 4 metastatic disease. And so I think that information helped revise the task force recommendations, and now they're tempered somewhat.
So the challenge with this whole U.S. Preventive Task Force is, as he was saying, it relied on a U.S. trial. What group of men have the highest rate of prostate cancer in the world? African-American men. So an African-American man has more than 2 times the risk of having prostate cancer and more than 2 times of the risk of dying of it case for case. So if you're going to do a trial where you're going to evaluate the effectiveness of the PSA, what group do you primarily need in your trial? African-American men. What percentage of African-American men were in the U.S. trial? 4.5%. So they based the results of a trial on a group of men that weren't even at high risk. That's like asking what's the status of sickle cell in a group of white people, right?
Yeah,
that's crazy. And so the study was flawed from the U.S. trial, which was a flawed trial because it really wasn't a screening trial because the majority of people who were in the trial had already been screened. Right. So the PSA screening works only if you're saying, what's the ability to pick up prostate cancer? Well, if a guy's already had 4 or 5 screens, chances are you're not going to pick up prostate cancer in that guy at a high rate because he's already been being screened.
Right.
And so the trial was a flaw.
Kevin, you're African American, and you started getting the test. Did your primary care doctor tell you it's time to start getting these tests? Or did you know the risk as an African American man?
No, when I started getting tested, I didn't know. But this is what I did. I went to the doctor in 87. I started getting yearly physical. I said, test me for everything. That's pretty much what I told them. Test me for everything, from ruler to the tutor. And then they said, well, you want PSA? I said, yep, give me that as well. So I got tested for everything. So that's how I started taking PSA tests, and I never stopped.
You advocated for yourself, essentially, and that led to your first PSA test.
Yeah, just test me for everything.
And is that based off this, what was it, American Task?
U.S. Preventive Task Force. So that's why you see these billboards. So there's billboards. You drive down 170, you see billboards. 1 in 6 African-American men have prostate cancer, PSA. And so the point is, it's very dependent on each individual primary care physician. So some physicians order PSA, like I'll see a guy and say, oh, that's Dr. Such. I know he's getting a PSA every year. You see him every year? Oh, yeah, I see him every year. He draws my blood every year. I don't draw that guy's PSA because I know that primary care doctor does a PSA on everybody. But it's very dependent. So we tell men, you better take ownership of yourself. You go in there and you're a 55-year-old man, you should say, doctor, are you going to check my PSA? Oh, that thing doesn't work. Well, let me rephrase that. Doctor, I would like for you to check my PSA.
Well, how frustrating is that for you all at Siteman Cancer Center, seeing these rates and knowing what you see because you're a research facility as well as a treatment center, how do you, that has to be frustrating when you find patient after patient that has advanced prostate cancer.
Yeah.
It really comes down to, why aren't you screening men who walk into your office who are over 50, and prostate cancer is the second most common cancer they could get. It's the most common cancer you could get, second causing cancer death. So why wouldn't you just send a PSA every once in a while?
We have these treatments, but as Dr. Bullock is saying, like it's the screening, it's catching it early. Once it's spread outside of the prostate into the bones, that's typically incurable, and so that's a longer, harder road.
Kevin, what are your thoughts on not knowing that this was such a high risk of getting cancer as an African American man, of this specific cancer?
I guess I really never thought about it because, like I said, I got tested so early on, so it never crossed my mind. Every year I would just get tested, and so it never crossed my mind not. But what I do, I tell all my friends to make sure you get tested. All my friends, hey man, did you get tested? You going to the doctor? And now they going into their doctor and say, test me for this. Because like Dr. Bullock said, they weren't automatically giving it to them, right? And these guys are in their 50s. And they say, now they're going and asking for it and getting it.
Is it an insurance thing? Is it an insurance issue that they
covered?
They'll cover it?
Yes.
Okay, so this is a matter of having to get the word out to all men. You have got to get your PSA test. And if you have a family history, you've got to get it earlier than that. Right. And if you're an African-American man, you have got to know your risk is even higher.
Correct.
It's just outreach and education. And in prostate cancer, though, I think we're a little kind of late to the game in terms of, getting out, talking about it, funding research. If you look at the funding for breast cancer research and all the outreach, the fund runs, et cetera, and compare it to what we've been doing in prostate cancer, we're years behind where breast cancer is. And it's equivalent in terms of incidence and, as Dr. Bullock said, death rates and all that. And there are some foundations like the Prostate Cancer Foundation that are really kind of leading the charge. We need more of those type of foundations and more outreach and education to make sure everyone knows about this.
Do you think it's because women talk more about breast cancer?
So this is, you brought up a good point. Like, why don't men talk about their prostate cancer as openly as women?
Kevin was just nodding his head.
I was going to talk about that.
Because, for some reason, men rarely talk about much anyway. And so for men to sit around and talk about health, that just is not a common practice. That's why such a podcast as this is so important, right? Mm-hmm. If you reach, 20 people where it has an impact and saves them, you say, wow, that was worth this podcast.
Yeah.
We're going to obviously reach more than that.
Right.
But we need people to spread the word to really, it's word of mouth that people have to hear about it.
We need more Kevins out there telling all their friends, because it only takes one guy to, for this thing to hit home, to inspire them to try to help somebody else. I would love to hear each one of your PSAs on PSA. I mean, I feel like we've hit in a couple different ways, but when you have that 30 seconds to 1 minute with the guy in the locker room, what are the bullet points that you're hitting?
Right, well, that's what I typically do. I talk to them about one. You got to get a PSA test. You're going to the doctor. It's important. I try to strike up a conversation. Because men treat prostate kind of like a scarlet letter. I know guys that got it that won't say anything about it. Mm-hmm. And we can always be talking about it, and they won't say anything about it. It's like a scarlet letter. They're embarrassed. And so I try to take the embarrassment away. If I can talk and save one person, I've done my job, right?
What about you, Dr. Bullock?
Well, the public service announcement is that, medicine has improved so much. And we have tests now that allow us to find out if we have disease at an earlier stage when it's fairly straightforward and all the options are in your pocket. But the later you delay evaluation and treatment, the Amoco commercial, you're going to pay later or pay later. Mm-hmm. Pay now or pay later, right? Being screened. And not just, we talk about prostate cancer, but whenever I go to a church tour or something, we talk about everything, not just prostate cancer, it's just overall health. And you've got to get your money's worth. When you go see a doctor, if your doctor's not asking about smoking and exercise and what your diet is, and we're going to time to get screened for colon cancer, time to check out your heart, then Doctors are a business. You got to go find another doctor.
That's right.
You're right. You go to a restaurant and they don't serve you water. Why keep going to the same restaurant? Mm-hmm. Right? And so I tell people, go in there with a list of questions and do what Kevin did. If I was a senator, what test would you be ordering on me at the age of 52?
Dr. Pachynski?
Yeah, I mean, I would say something like a PSA test is super easy to do. You know, it's not a mammogram, it's not a colonoscopy. If that PSA is elevated, you've got a little time to kind of figure things out. And now, as Dr. Bullock was saying, we have better ways of looking at the prostate cancer, imaging it, molecularly, genomically testing it, and figuring out what kind of dog this is. Mm-hmm. Do you even need treatment right now? Can we wait a little bit? Do you need to do surgery? Do you need to do radiation, something more? But the test is easy to do. And so I think, you know, just having people understand that and ask for it, I think is important.
Could we start seeing some of those mobile vans for PSA tests like we do see mammogram vans?
We've worked on them. Many of the prostate cancer initiatives, you know, Siteman, the PCAT, the Program for the Elimination of Cancer Disparity, mm-hmm. And our people, Keisha Williams is over the prostate arm of that at Siteman. I bet every week she's at some church or some community event doing screenings. Siteman is all over the place. So we screen with personnel actually at these community centers. They register you, they draw your blood, and we end up mailing them the results. People with an elevated PSA, for some reason, I get a lot of those results, and I send them a personalized letter and an invitation. Even if they have no insurance, we figure out a way to get them tested and treated. There's a lot of groups out mm-hmm. there on a weekly basis. Where do you get a PSA if you don't know? There's, what's it called? A Screen Now. What's it?
Get Screen Now.
Screen Now. That's
yes.
right. If you go on the website and you type in Get Screen Now, every day there's a place you can go get a free PSA. But it's not just PSA. I think it's on that site. We'll tell you where to get a colon screen,
any screen,
mammogram,
yeah.
any screen.
In the St. Louis and Illinois area, correct?
Yeah. Mm-hmm. Get Screen Now.
Well, I learned a bunch speaking with you three gentlemen. I appreciate you all coming in. Kevin, thank you for sharing your story. Doctors Bullock and Pachynski, thanks for sharing your expertise. I'm certainly going to try to go forward and be a Kevin for my friends and make sure that everybody gets screened whenever they can, because it's too important to miss out. So it's a new year now, and you might as well start it on the right foot. So go see a primary care physician and take an active role and look out for yourself. Be an advocate. Thank you, gentlemen, all for being here today.
Thank you for having us.
Thank you.
Happy New Year.
Happy New Year.
Thanks for listening to This is Cancer, brought to you in partnership with Siteman Cancer Center at Barnes Jewish Hospital and Washington University School of Medicine in St. Louis, national leaders in cancer.
For more information on Siteman Cancer Center, go to siteman.wustl.edu and be sure to leave us a review and like and subscribe wherever you listen to podcasts.